So as far as preventive measures, isn't it true that cancer cannot start or survive in an alkalized environment? Cancer can only occur in an acidic state. So this whole acid-base thing is actually very common to the discussion on colon cancer as well. So this similar question was asked.
All bodies are at a neutral pH, so I actually had no idea how you measure an acid or an alkaline body, because if your body's alkaline or acid, you're probably close to dead. So it's it's a sort of thing the naturopath, the alternate practitioners talk about, but we measure pHs. They better be neutral because that's how our bodies are. So I can't tell you anything about that. I mean, breast cancer starts in breast because it does, because it's gotten damage, because you're genetically prone, or just because. And probably the just because has happened when you were a teenager, not recently. And it's multifactorial. If we knew what caused breast cancer, we would prevent it. We don't know what causes most breast cancers.
What can someone do who's been diagnosed with breast cancer, who's had surgery as well as other treatment, what can they do to minimize the recurrence of cancer?
There are a number of studies that look at how, because everyone who gets it, they don't want to get it again, right? Once is enough, thank you. The live well, eat well, be well certainly is the basic thing, which sounds pretty basic, but the fatter you are, if you smoke, if you don't exercise, statistically you're likelier to get your cancer back. There's certainly been a number of studies that women that go out and exercise, and I mean exercise, that doesn't just mean walking to the fridge and opening it, that means going out there and doing 4 hours a week of exercise. And it doesn't mean you have to go to the gym, but you can walk 2 miles, you can do whatever it is. That lowers the risk of recurrence by about 20 or 30%. Certainly being an obese woman increases your risk. It probably has to do with your estrogen storage, and you're probably also not moving except towards the fridge and back. So that basic the basic things that we talk about, cardiac prevention, the general healthy things, actually do have a role in reducing the risk in breast cancer. Now, people do all that stuff sometime, and the cancer comes back again, and they're extremely hostile about the fact that it's come back. These are risk reductions. It's the best thing you can do, but it's not a guarantee. But, of course, every little thing you can do is you should do for yourself to try to help.
Another question is, what is the typical follow-up procedure after you've had your breast cancer surgery and treatment? And who does this, the cancer agency or your primary care physician?
Most breast cancers, unless they're high risk or you're on a special study, are usually not followed by the cancer agency or specific surgeon because it just can't be done. I mean, I will see a number of 100 breast cancers a year. If I followed everybody, by the time 4 or 5 years goes past, all of the patients are follow-up because there's no room for anybody else. And it's kind of the same for the cancer agency. So they'll focus in on treatment and then seeing you have a problem or a high-risk patient that has a high risk of coming back. So they will not follow everybody. It physically can't be done. So the idea is that your family doctor will follow you. And there aren't a lot of tests that need to be done, because really what you're following is there cancer coming back in the breast, is there cancer in the other breast, and those are the things that we can treat. There aren't a lot of tests recommended, and this actually pertains to the United States as well. No one's going to want to do x-rays of your chest. No one wants to do regular bone scans. No one wants to look for cancer spreading, because the ugly truth is once it's spread, it's incurable, so why do you want to know earlier? No one's going to treat asymptomatic metastatic disease usually. It's only when you have symptoms. So you search for the things that are fixable, which is usually cancer in the same breast, cancer in the other breast, or cancer in that area. Mammograms are important. Physical exam is important. Every 6 months is probably important for a physical examination.
Okay. Someone had a question about being on hormone replacement therapy, I presume, and they want to know what the risk of breast cancer is if one continues to take hormone therapy.
How come these questions are all for me?
They're going to hit me later.
Hormone replacement therapy used to be, when I first started practice, the big fashion. Every woman was supposed to take it till the day that they died because it was the best thing that was made. Some of us are a bit cynical about this because hormones and breast cancer do go together. Even though most breast cancer is in older women, the breast stays active when you take hormones. and there certainly has been a number of studies that have indicated on this, there's a higher risk of breast cancer if you take hormones. That doesn't mean you're going to get it. It's just statistically it's higher. But if you only have, say, 3 people out of 1,000 that got breast cancer because they took hormones rather than they didn't, if you're looking at 1 million plus women, it actually adds up to a fair few women. The current recommendation is take the hormones for symptoms. Use the drug for symptoms. So if you're having postmenopausal symptoms, I don't see any reason why people should withhold unless they have a good reason that they can't be taking them. But if you take them for more than 5 to 10 years, your risk of breast cancer is higher than the woman who hasn't taken them. Now, for some women, they'll weigh the balance and say, well, my quality of life is better. I'll take that extra risk. That's their choice. And I don't know whether family practice has any different ideas on that at all.
I think the data suggests your risk of breast cancer definitely goes up the longer you're on hormone therapy. So the recommendation is that it's just symptomatic and short term, because they've also found increased risk of breast cancer with longer duration and also of having clots in your veins, venous thromboembolism.
And more heart attacks.
And for heart attacks. So there's increased risk. So, obviously if someone's having unbearable hot flushes, they might have a short-term hormone therapy, but it's not something that is recommended for long-term treatment of those symptoms.
In all honesty, when we're on it all the time, I remember Susan Lovin had the discussion, and she said very cynically, do you know how many millions of dollars that is in untested therapy?
Yeah. So I guess someone heard your call, Nancy, and they wanted to know, how do you actually make the nipple when you're reconstructing that in that third set of operations for the reconstruction? She's handing it over.
I use a piece of skin graft that I harvest either from the mastectomy scar or the tram scar. So it's a piece of full thickness skin that is used to make the areola, which is the disc, the round part around the nipple. And the nipple itself, the prominent center core, I make by raising a little flap, by taking whatever subcutaneous fat is underneath where the nipple is, cut around it, and I pull it up and put what I call a purse string suture around it to tighten it down. And then in the process of pulling that skin up, I've created an area where there is no skin. That's what I put the areola on as a full thickness graft. And I pull the nipple through it, and I do a little tie-over dressing, it's called in the OR, to make sure that the skin graft stays applied to the site. And that's all done in one stage. And the patient will have usually it's a waterproof dressing over that area for a week so they can shower the next day and start exercising and stuff. I do that technique because it gives a 3-dimensional nipple. Some of my colleagues just do a little flap, which gives the nipple prominence, and then they tattoo the rest. But if the nipple goes flat, which it can do with just that kind of flap, and you have the tattoo looks a bit odd if it's just a color on the breast. So I kind of like to have the 3D nipple, which I think you could see reasonably well on the screen. They look pretty natural. They don't go up and down, if you want to use that term, and they don't become erect like a natural nipple would. So I don't usually make them really prominent because then they're hard to hide in a t-shirt and in a bra. So you go from one problem to the other. So it's sort of just enough to give that hint of elevation. So, I mean, I'd like my patients to be comfortable in a public change room, taking off their clothes and having a shower, and just, if you glance and you see 2 nipples of a reasonable dimension, it looks like a real breast, and that, I think, is really key. I have sometimes difficulty encouraging women to have the nipple made because they go, oh my God, I've had so much surgery, I'm tired, I don't really need it. And I let them wait a bit, and I usually encourage them, particularly if I can do it under local, it seems less daunting than going back to the OR again. Every single time I've encouraged them to have it done, they come back and say how delighted they are because now it feels like it's finished, it's completed. They don't look in the mirror anymore. They step out of the shower. They have 2 nipples. So it's a small thing, which seems to make a huge difference.
Great. Another question is, how is one eligible to be tested for the BRCA1 and BRCA2 genes?
Most breast cancers aren't genetic. Only certainly less than 10% of breast cancers are genetic. The genetic, it is done through the cancer agencies, through the genetic clinics, and their criteria are pretty stiff because as I said, most people aren't genetic, so they usually require 2 first-degree relatives that are premenopausal with breast cancer. That's got to be sharing half your genes, a mother or a sister. If it's on your father's side, it can't obviously be a first-degree relatives, but they're looking for a lot of relatives. Or if you personally have an unusual age of presenting with the breast cancer, and that would be sort of under 30, 35. A lot of people have one relative, maybe a grandmother, an aunt with breast cancer. You do not qualify for genetic testing because it's unlikely to be genetic. You can look at the families. It's quite simple. You'll have somebody there who's 35 and their mother had breast cancer at 45 and their aunt had breast cancer at 50 and their grandmother had breast cancer, and you can see a pattern pretty quickly. Those are the ones that would benefit from the genetic testing, and those will be tested. But the genetic clinic has fairly strict criteria where they'll take you. You just can't go and ask for it.
Another question is around having biopsies that have showed atypical hyperplasia, and what proportion of these women who have these kinds of biopsies, what's the risk of having breast cancer? Or are they completely different phenomena, and is there anything you can do to prevent?
Well, I'm assuming that the question pertains to someone who's had an open biopsy with atypical ductal hyperplasia, because, believe it or not, I'm giving a lecture on this in a month's time. No, there's 2 ways that atypical ductal hyperplasia are picked up. One is on a core biopsy that you saw for the abnormal mammogram. If you get atypical ductal hyperplasia in a core biopsy, then the suggestion is that you have the whole area removed, because about 30 to 40% of the time it's actually an early form of cancer. Now, if you have atypical ductal hyperplasia in an open biopsy, you've taken the whole piece out, then that is a risk predictor for cancer in the future. The risk actually depends a little bit on the family history as well, because it's an additive factor, but with no family history, atypical ductal hyperplasia, the risk of getting cancer in the future is probably goes up to about 25%. If you look at a relative risk, it's 7 times a relative risk. So it's a significant risk predictor for either breast. Prevention, of course, there's nothing that's guaranteed prevention, so obviously the live well, be well is one thing. There has been a number of prevention studies that we participated in here that I've been involved in, and tamoxifen is a risk reducer, raloxifene is a risk reducer in a postmenopausal woman, and there is an ongoing study looking at the aromatase inhibitors in the postmenopausal group. Most of the risk reduction for those medications is about 40 to 50%, so it's risk reduction, not preventions. So it's a matter of adding all the things that you can do together. Most people won't take drugs unless they really have a significant risk, even though it's offered to them. Most women will choose to do the healthy lifestyle as best they can.
And at what point of the diagnostic workup does the patient learn what type of breast cancer they have or their stage? So just if you go back to when would they figure that out, like in terms of the...
Well, the core biopsy will often tell you whether it's invasive or it's in situ, but it doesn't give you much more. It's when the lump is taken out, when that surgery is done, whether either the mastectomy is done or the partial mastectomy is done and the lymph nodes are tested, that will give you that the pathologist will look at the whole specimen and will tell you the size, the grade. It's after the first surgery that you have all your information, basically.
And I guess somebody heard about the age limit and wondered, are mammograms for women over 80 not required?
Screening mammogram, the idea of a screening mammogram is to, I wouldn't say save lives, but people look at what the competing causes of mortality are. Once you get to be over, and what they're looking at in screening mammography, and it's not really ageism, because if you want a mammogram at 80, they won't turn you down, but they're not inviting you to screening because what screening is supposed to do is increase your 10-year survival rate. So once you're past 80, screening for breast cancer probably isn't going to increase your 10-year survival rate over and above where you already are at. So there's a point of where it sort of as a public health maneuver, it isn't really helping. The reason it's not the young women is because the risk of breast cancer isn't very high, and the mammogram is relatively inaccurate in that age group. But the upper limit had to come somewhere, and really what the condition is how long are you likely to live, and does it make any difference if you pick up your tumor when it's smaller or bigger, and statistically it doesn't increase your overall survival.
Breast cancer in men, is it the same or a similar phenomena? And in terms of the symptoms, the diagnosis, and management?
Interesting you should ask. I just had a 36-year-old guy with breast cancer with tattoos that started at one elbow and went up the other, so he didn't look like a high-risk guy. Breast cancer in males is relatively uncommon. It usually presents late because guys don't think they've got it and they just wait for this lump to grow until it's bad. But it can be picked up at an early stage. And I think it is more now because it just seems there's more awareness. Stage for stage, the outcome is the same. It's just traditionally it presented later when it was already stuck to the chest wall or when the lymph nodes were involved. But it is pretty uncommon. It's 1 in 100 breast cancers maximum is in the male age group.
And is it any age group as well for men?
Well, remember I said I've had actually 3 male breast cancers this year. One was 45, and he was a skinny little mechanic, and one was 36, and the other one was in his 60s. So I would have to say it's across the same sort of age group.
Okay. One question is around taking the oral contraceptive pill. Does it increase your chances of getting breast cancer in the future?
I have a tough time answering that because there's so many studies, and you may know as well as I do. From my knowledge on the low-dose birth control pills probably taken for a reasonably short period of time, i.e. less than 20 years, I'm not aware of any increased risk, but the old birth controls were a higher estrogen, higher progesterone, and women took them for longer. But you can read a gazillion papers, and some say there's less and some say there's more, and it probably comes up pretty much equal unless you're in the over 40 age group. I don't know what your knowledge on that is.
I think it's pretty much that.
Yeah.
And the question around pain in the breast, is that an important sign of breast cancer?
No, pain is just women's burden. No. Pain in the breast is almost always a benign phenomenon, and it's common in the 40s decade, and it occurs in at least 30% of women in that age group. Very occasionally, a breast cancer hurts. So if you have a lump that hurts, it still has to be investigated as any other lump, but usually it's not cancer.
Okay. The last question that I have is sort of a general question about what is considered treating right in treating cancer, and I think both speakers kind of took us through the pathway of, early diagnosis, getting the screening, getting access to the specialists that you need to see, and coordination and multidisciplinary care. And I think it really, both of them spoke about how important it is to work together and work closely and have those relationships where each specialist understands what the other one needs in order to get the best outcome for the patient. So I think both of them summarized what treating it right would look like. It's having that collegial, professional working relationship and having the patients be able to access as seamlessly as possible all the expertise that they can when they need it.
Yes. What's that? I did mention the clinic.
She would like to do another plug.
Here I am, the advert. No. As I tried to mention in the middle of my talk, we know that there's been a lot of delayed diagnosis over the whole region, and the whole point of this clinic being set up with special money, and I think the whole idea was there'd be more clinics in the Lower Mainland as well, as to get women in the system. They do have to be referred by their family doctor. They do have to come from screening mammogram, but the whole idea is to quickly get them a diagnosis. And one of the ideas is to quickly get them the diagnosis of it's not cancer, because believe it or not, that's just as important as it is cancer. So Mount St. Joseph's has set up a rapid access clinic. It's the first one in the city, and it is working, and the whole idea is to put you out of your misery earlier. No, I'm not.
If you have a diagnosis already, is a rapid access clinic worthwhile?
If you
already have the diagnosis?
No, this is to make the diagnosis. Okay, this is to try to shorten the time from, geez, I found a lump, and 2 months later I had an ultrasound, and 2 months later, it's to shorten that time to diagnosis, be it cancer or be it benign. Once you have a cancer, it's not a clinic to deal with cancer unless it's come through that clinic, in which case we'll just keep you going through the right steps.
So you mentioned about they have to come from the screening mammography arm of them. What about if you had your screening mammograms and then you're onto the diagnostic mammograms? Can you still access that from there, or is that something?
Well, we've had a lot of discussion about this one way or the other because the whole point is to get a rapid diagnosis. If usually the advice is that whoever started there's many screening centers and they're attached to diagnostic centers, and the hope is that they would follow through on the process, because if they started and they all came to the rapid access clinic, then it would all of a sudden be so bogged down that it wouldn't be able to give you a fast diagnosis. So the hope is that wherever you started, it would go through. And for a while, we were turning down patients from elsewhere just to be afraid that, if the doors are open and the whole room fills, you can't sort them out anymore. But I think the criteria will be a little bit open. But the hope is that where it starts, you'll at least keep going, unless you're not having any success there and it's taking too long. Cheryl, is that the kind of consensus we've come to? We've argued about this back and forth. You see.
So the long-term objective is to try to get clinics like this all over the place. Because they've got them all over Europe, and we're the first in Canada, really, that we know of. And so we're trying to see success, and then there will hopefully be 2 or 3 more in the Lower Mainland and some Syria. So the idea is we don't want to be on everywhere, but we don't want to bring it from everywhere.
Well, you can't.
We can't, yeah, we wouldn't be able to do it.
So who refers then? Is it one special screening?
It's a family doctor from anywhere around. Okay, if you have a lump and they want that dealt with, it's a family doctor. You just can't walk in. It's a family doctor that refers, or if you come from the screening program within Mount St. Joseph's
Or women. We also have an arrangement.
So it's the screening program at Mount St. Joe's?
or women's, yeah.
So just those two. So somebody who gets screened in Surrey doesn't go to the
No, the hope is that they will. They actually were working on their own program. I don't know where it came to. You got it? Yeah.
No, I'm working on it.
Yeah. That's because I said, no, we don't want to. We want to encourage.
To replicate the model
Local.
in other jurisdictions.
Yeah.
And then is it any family doctor in Vancouver?
We said any in Vancouver for our house.
We just said any in Vancouver because, again, you want to limit what you can do, because if you try to do too much, then you will not do it because
It won't
you'll
be
be too
rapid
flooded.
access
It won't be
anymore.
rapid anymore.
After the biopsy, they say that it is not cancer, and then go here and then you go for mammogram. If you find that you have abnormal gain for the breast, and then will it be any how do you call it, cancer again? Is it biopsy? Is benign, always benign?
If you're talking taking the lump out, that's one thing. But if you're talking the needle core biopsy, if you take the lump out, that lump is gone. So then if you go for a mammogram and they find a different abnormality, you're back to square one. You have to, that's a new problem.
So we have to go all over again, go to the biopsy again, and all the wire biopsy.
Well, hopefully a lot of the time it can be done with a needle core. Remember those pictures I showed you? You could do needle biopsy under ultrasound or mammogram. Our hope is that most people, especially for me who has to do the surgery, don't need the surgery, that you can make the diagnosis from a less invasive perspective. Now, some people do need another open biopsy for special circumstances, but a new problem is a new problem and can't kind of be ignored.
So, but if they say benign is not sure all the time with benign, sometimes not benign. That's what the answer is. Right?
Yeah, things change from year to year. We grow older, we grow new things. You can't assume because it was benign 2 years ago that something new is benign. It's a new problem, is what I'm trying to say.
About the same breast.
Yeah, it doesn't matter. If a different area, same breast, new problem.
So I'm going to draw the question and answer period to a close and invite you to join us out in the foyer there and look at the materials that we have, and we'll be around for a little bit for questions. And thank you very much for coming. And the next one, like I mentioned earlier, is on October 21st. And please come or invite others that you think would be interested in healthy aging and elder care as well as fall prevention. It's by Dr. Janet McElhaney and Dr. Wendy Cook. And I'd love to thank our speakers, Dr. Kuusk and Dr. Van Laeken, for an excellent presentation. I think all of us learned a lot, and we really appreciate them sharing their expertise with us.